Our next speaker is going to talk about something that's really very important to our patients. And we heard about this earlier, and we recruited Dr. Tony Sung to help us with this. Dr. Ahmed oversees our survivorship program. And I think the attention that survivorship deserves and warrants to see should be that this room is overflowing in standing room only. And the fact that we've whittled down a fair amount here is a testament to we got to do a lot more education, because this room should be packed with people, because increasingly our therapies are allowing patients to survive long term, and we're creating for those patients increased risk and challenges that are disproportionate to an age-matched population, patients who haven't gone through what they've gone through. In that regard, it's my pleasure to introduce our next speaker, Dr. Richard Newcomb. Dr. Newcomb grew up in Dallas, Texas, which means we have a reasonable shot at recruiting him back to this area because it's not that far of a drive to Dallas, and it's very expensive. Look, Boston is the most rich medical environment on the planet, but you're going to be as poor as a church mouse the rest of your life. And okay, he majored in the history of science, earning an AB at Harvard. Before attending medical school at University of Chicago. He subsequently did his internship and residency at Mass General, and so that's unfortunate. He's getting deeper and deeper roots in Boston, and served as the chief resident as well. He completed a fellowship in hematology oncology at the Farber Mass General Brigham, and that mixture is different now, I think, and it changes every couple of years, right? In 2023, he joined the staff of the transplant program at MGH. His clinical and research interests revolve around improving the quality of life and experience for patients with blood cancers, particularly those undergoing stem cell transplantation. Welcome, and thank you for being here, Dr. Newcomb.
All right. Thank you so much for having me. I've done the drive from Dallas to here many times. I used to have cousins that lived in Olathe, which is not so far from here, and always like coming back for Kansas City barbecue, though I do prefer my brisket ultimately without sauce, so, but I won't hold that against anybody here. So today I'm going to talk about building a formal transplant survivorship program, the things that we've learned at MGH, the impact that it's had, and some future directions. Here are my disclosures. So I think there are four main objectives that I'll try to get through. One is to just establish the need for formal survivorship programs, to explore what those needs are, both at the medical and at the patient experience level. Talk about how our survivorship model tries to address both of those needs, and then talk about some unmet needs and things that we still need to do and push this field forward. So why survivorship? I hope this is going to be relatively evident by the end of my talk, but for the past 2 decades, we've had incremental increases in survival post-allogeneic transplant, and by 2030, we're projected to have over 500,000 transplant survivors. Why is that? Our pre-transplant therapy is better. We have better transplant regimens. We have better supportive care. We have better ways of treating relapse disease, though that remains certainly a challenge. And so, we've, for a very long time in our field, considered what is a good transplant outcome. We say you got to be alive, you need to be free of GVHD, and you need to be relapse-free. And increasingly, we're hitting those benchmarks. I just showed you the data. More people are alive. We're getting better at GVHD prevention. Relapse, remains a very big challenge in the allotransplant field. But I would argue that as we get people living longer, survivorship is ultimately the true frontier that we have to address, and we heard that plainly and clearly in our plenary session today. Here's just some data just for me to show you that GVHD remains an important thing, but we're getting better at preventing it. So 1703, establishing PTCy as a standard of care. So chronic GVHD is a very important part of survivorship. Just to put that disclaimer out there, I'm not going to be spending a lot more time talking about chronic GVHD today, and that's a real privilege. Again, we are driving toward better transplant outcomes for all of our patients, so let's talk about survivorship. So what are these challenges? One is that we still have a survival gap. When you take transplant survivors to their age-matched controls, we have to figure out how do we address that. There are a lot of medical issues, a lot of which are related to treatment-related late effects, and then there's quality of life impairments, again, so many of which we heard about today in our plenary. And I think every transplant program is going to have a number of motivating cases. I'm going to put up 3 similar cases that have been described to me by the folks who started our program, but this is why we care about it. So you have a 73-year-old woman who's 4 years out from an allotransplant. She falls, breaks her right hip, goes to the ICU for an aspiration pneumonia and sepsis, and she never had screening for osteoporosis. A 62-year-old who's 7 years out from transplant comes in with a chronic cough for 3 months, ultimately gets diagnosed with metastatic colon cancer, and screening colonoscopies that actually just had fallen off the radar after transplant. And a 66-year-old with chronic GVHD who's admitted to the hospital with acute myocardial infarction, and just the cardiovascular risk had never been fully appreciated. The list could go on, and again, we heard in our plenary session today on the quality of life experience side of things, that even when things go really well, our therapies take a toll on folks. And so that was really the motivating factor behind when we founded our survivorship program in 2016. Pictured here are Arij El-Jawari and Julie Vanderklish, who founded the program. Julie still works with me to lead the program today. Arij sort of is my research mentor and has invested a lot of time into this effort of improving the quality of life of our survivors. But we founded this program to provide high-quality survivorship care, to conduct innovative research, and improve the quality of life and care of our transplant survivors, their families, and their caregivers. So let me tell you a little bit about how we went about trying to figure out what are survivor medical needs. And the good news is I don't have to tell you all of it from the medical perspective. Just last year was published new consensus guidelines from ASTCT and EBMT came together to provide survivorship recommendations, which are, they're exhausting. Just to go through them, there's a lot that went into that. Again, I don't need to spend too much time on this, but just to say that allogeneic transplant affects every part of the body. So cardiovascular system, whether that's cardiomyopathy, arrhythmia, stroke, MI, metabolic syndrome, pneumonia syndromes, interstitial fibrosis, BOS, osteoporosis, osteonecrosis, hormone deficiencies, and predisposition to having infections, particularly those who have IgG2 deficiencies, and then second cancers that can come up for folks related to transplant procedures, specifically radiation. So I want to spend a little bit of time talking about the cardiovascular side because I think it kind of provides an insight into, yes, there's all these problems and they can be really overwhelming, but when you break it down, you can actually do stuff for patients in a formal way. And whenever you think about any of these risk factors, it's a matter of saying, okay, well, how do we define the effect? What is its actual burden in our patient population? What are the things that contribute to it? Are there screening things that can identify issues that we can make action on? And then ultimately, how can we prevent these bad late effects? And so just like I was saying with cardiovascular disease, we now know that up to 50% of our transplant survivors have metabolic syndrome, and that they're at twice, at least compared to general population, the increased risk of hypertension, diabetes, hyperlipidemia, and all those things lead to higher rates of real things like MIs and stroke, and those are big problems, and they can be easily caught. Cardiomyopathy remains an issue, particularly those with high exposure to anthracycline and total body irradiation. So we know that cardiovascular disease burden is high, and as we get better and better at preventing chronic GVHD, this is going to be the main reason why patients will die early post-transplant. There are lots of things that go into that, and that's part of the thing that makes survivorship so challenging, is because you have patient-derived issues that they are bringing to transplant, so their prior medical history, their prior exposures. You have the cancer itself and the treatment, and then you have transplant-related factors. So it's really hard to make one cookie-cutter model to say for any survivorship medical issue that this is what you have to do, because the truth is that all these factors are interacting, and it's your job as the survivorship clinician to try to tease those things apart so you can isolate for somebody, hey, I have a plan for you, right? But this is complicated. There are risk scores that can help. This is the CARE BMT score, which has actually been studied in transplant survivors. There's obviously, general population cardiovascular risk scores like pooled cohorts or ASCVD, but I like the CARE BMT model because it kind of takes into account all those things about who the person is, how old are they, do they have comorbidities, what was their prior treatment history as it relates to anthracyclines, and then what are other medical conditions may they have, and it puts people into nice buckets, and you can kind of say, at a very high level, are you low or high risk? At now that you're at a year post-transplant, how aggressive do we need to be about this? And then the good news here is that we have stuff we can do, right? Like we have very easy blood tests, imaging tests to assess how people are doing post-transplant. There's lots of good lifestyle modifications. Those are the hardest things to do in medicine. But it turns out most of our patients are super motivated to do that. It's always really interesting to me if I'm talking to a person in survivorship clinic, hey, let's talk about exercise versus adding a statin. They're like, I don't want to do any more medicines. It's like, we just went through, I just gave you 80 million different medicines to take for a year, and the thought of adding a statin can be completely overwhelming, but this idea of talking about a structured exercise program, they're all about it. So I think that, again, we have the multiple three-pronged approach here, which is, I think, great that we're able to do this for our patients. And truthfully, I'm not going to go into every medical need, but each medical need that I outlined earlier, you can do a similar approach, right? Whether that's screening for BOS with early PFTs so you can get people on appropriate therapy, whether that's being really, really religious about getting post-transplant DEXs and doing bisphosphonates for folks so that you can prevent fragility fractures. Screening for hormone deficiencies so people can, a lot of the issues that come up post-transplant, again, this is easily found, easily replaced. Infections and being vigilant about IVIG for folks that really need it. And then age-appropriate cancer screening or something more in-depth in case there actually is a familial or a germline issue that is relevant. So each one of these medical things you can do things about, you just have to be very systematic about it. And to be truthful, there's more stuff here that you haven't even covered, whether it's kidney disease, liver disease, cognitive dysfunction, ocular health, dental health, and you heard it this afternoon. This is overwhelming. I think I often hear from long-term survivors that they've had to put together a whole cadre of folks, and people who are 10, 12 years out, they had to do that themselves. And it's really remarkable that they did that. But how can we be better? And so the first step is just identifying our treatments really affect people very holistically. And that's why I firmly believe that survivorship risk assessment is an art. You have to take into account all these factors and then make a plan that's salient and personalized to somebody. And that takes, I think, some formal structure to it. And so just to put that kind of in perspective, when you're seeing a 32-year-old woman with TALL who's a year out from a TBI-based ablative transplant, that survivorship plan that you're ultimately going to give that patient is going to look, very heavily focused on cardiovascular health, addressing premature ovarian insufficiency, making sure they have really, really good cancer screening plan in place, that they have a plan for their bones, and that you're making sure you're screening them with PFTs, that they're not going to develop any pulmonary issues. That's going to look really different from a plan for a 78-year-old guy with MDS who's a year out from his reduced intensity transplant, where you're still probably going to care about cardiovascular health, but you're going to be really attentive to the cognitive changes, to the bone health, to the ocular health. These are, like I said, no cookie cutter model, but really getting to the heart of what are somebody's medical needs is a really important part of building a survivorship program. So takeaways from this part of the talk is just that, again, transplant affects every organ system. As we get better at GVHD prevention, this really is the focus for transplant survivors, and it has to be personalized and tailored. Now, again, we heard that it's not just about the medical stuff. People's quality of life really takes a hit post-transplant. And their experience is equally critical to their survivorship journey. In fact, every survivorship consult that I do, I spend the first 30 minutes just saying, what do you want to talk about today? What are the things that are bothering your everyday life? And these are the things I hear, I have depression, anxiety, trauma. We heard that very loud and clear today. I'm just tired all the time. I can't do the things I want to do. People don't tell me this, so you have to ask about it, but they'll say, my sex life isn't what it used to be. I'm not sleeping very well. I can't work, or I can't work in the way I want to, and I'm just terrified every day that my cancer comes back. So these are the things that people will actually tell you. The medical side that I just went through, those are the things you have to do as a physician or a clinician to figure out what are the medical issues that they have to care about. But these are the things that are actually impacting their day-to-day life. And just to spend a little bit more time talking about sexual health, because I think this is a really, really important educational topic, but 60% of men and 80% of women will report some form of sexual dysfunction post-transplant, and they're not going to tell you about it unless you ask, so please do. And this greatly impacts quality of life. It increases psychological distress. The good news is a lot of this stuff's actually addressable. So for men, biological causes like thinking about erectile dysfunction, hormone deficiency. For women, again, age-related processes like atrophy, but also transplant-related processes like vaginal chronic graft-versus-host disease. These are things we can do something about. Sometimes it's more than just the physical aspect, but there's actually a loss of intimacy or loss of interest in sex. That we've developed supportive care interventions around these very, very important issues to help folks out. And you don't have to just deal with this alone. There are providers in gynecology, urology, reproductive endocrinology who can often help. And we've found that when you ask patients about this and you have something to offer, they're really happy about it because they get back a part of their life that they thought they weren't going to get back. And that's really, really rewarding. So, this is just one tiny example across all the different patient experience things that I relayed to you, but you can really make a difference. And my mentor, Rij El-Jawari, has made both a clinician and a digital health application intervention around this topic, which are now being studied in a multi-site fashion. So we're hopeful that we can get some of these interventions out across especially the app, out across transplant centers. Of course, these issues, both the medical and the experience things, do interact with each other. And chronic graft-versus-host disease is a really good example of that. So, if you have chronic graft-versus-host disease, then the experience just worsens all the way across the board. And this is what this very old data shows. On the x-axis are a number of patient-reported outcomes. On the left are functional outcomes. On the right are emotional outcomes. And you can see the presence of chronic graft-versus-host disease across all these instruments decreases your scores, leading to decreased functioning and decreased emotional well-being. And then, of course, as the chronic graft-versus-host disease is worse, the impact on both total quality of life as well as on physical functioning is also worse. So, again, these things interact with each other. And so, as we put together what our survivorship needs, both on the medical assessment and on the survivorship experience, those interact with who this person was before transplant, and then you kind of put together a whole picture for somebody. So as we built our program, these are the things we were considering. And you can just imagine this is hard. This is really difficult because this is incredibly comprehensive, and to take somebody through this journey is a lot. And so, because effectively, like if you think about it, if you were just to refer for every one of these issues, then people would have no time left in their day. This would be like an 80-hour a week kind of job just to address all your needs. And access to specialty services may be incredibly variable. This is going to incur high cost to both patients and centers with a lot of logistical challenges. And truthfully, I don't think that patients or transplant clinicians even want that. So when you're thinking about I found all these needs, how do I develop a program that will actually systematically address them? People have thought about different things. Is the transplant clinician going to do this the whole way through? Are there going to be, cancer center-wide survivorship programs that do this? Should we be relying on our PCPs and kind of have a hybrid model, or should the PCPs actually entirely own this? And this is a graphic from a recent editorial in TCT about this sort of idea of conceptual models as people are really sick Like maybe there's a different survivorship model in the first year of transplant than there is 10 years post-transplant. But all this just to say is we don't really know what the best survivorship care model is. And we haven't really studied that in any rigorous fashion. So I'll tell you a little bit about what we do, and it's really based on this data. At least I feel strongly about this, that when you ask transplant clinicians who should handle survivorship care, in general, over 80% say, I want to be involved in it. And when you ask transplant survivors where they want their survivorship care to come from, 3/4 of them will say that they really, really value the transplant clinician's input into survivorship matters. So I take this data to mean that we need to take a heavy role in it and that really matters. And that's kind of how we've built our survivorship program, which is what we call integrative consultative care. And so we believe survivorship begins early. I would argue it actually begins during your transplant admission with building people's coping skills. And we know that through the involvement of specialty palliative care during transplant admission, you can actually decrease longitudinal trauma. So I would say survivorship care begins the second, like you as a transplant clinician become involved with them. And we need to figure out a way to make that a sustainable model. But then we sort of try to formalize it at day 100 with a full visit from the nurse practitioner, who's that primary nurse practitioner involved with the patient to go through early survivorship topics. That's chronic graft versus host disease education. It's getting the cardiovascular screenings, the bone health, the PFTs, the referrals that we think need to happen. And we do that all at day 100, and we do it early. And then those survivorship screening domains, they continue to get addressed by the primary team represented here in the blue arrows throughout the continuity of their care. When people get to a year and they're documented being in a good remission, we then have a team of transplant clinicians who are specialized and trained in survivorship who do a consult visit, sit down with the patient for an hour, go through their needs. We do a patient-reported outcome assessment. We do a comprehensive review of their medical history, and the output of that is a comprehensive care plan that gets shared with the patient, the transplant team, as well as their primary care doctor, when we can get access to the primary care doctor. A lot of our patients now, unfortunately, just don't have primary care doctors due to shortages in the New England area, but ideally, those are the stakeholders in place. And the idea is that that care plan can then guide the rest of their medical care, and that they can take that with them if they move out of the Boston area. So this is what we call an integrative consultative care model. And I think what's contingent on this is that, and this is in large part due to Eben, but he has allowed us to create a culture that survivorship matters, that this is a thing that we own for our patients. And we have a group of clinicians who are transplant clinicians who serve as champions. We provide comprehensive training to both the physicians and the APPs. We keep up to date on the literature, update our own internal documents, and provide ongoing education. We're just finishing up our most recent survivorship boot camp session, which has been really a great delight to get to and build team camaraderie around this. And then we continue to run this consultative service, as I've discussed. Of course, one area of privilege I have to admit is that we do have a wide cadre of specialists that we work with in cardio-oncology, in the surgical subspecialties, gynecology, reproductive endocrinology, ophthalmology, that we found that we have made over a period of time. And we think that's obviously a really important part of what we do. And then finally, to develop a robust research infrastructure in some of these areas. Talked about this kind of as I was talking about the program, but I can't emphasize how important this is to have formal education efforts around these topics for your clinicians, because without this and without the support that it provides, this stuff can be very overwhelming. Because this is basically like the hardest of primary care for really complex sick patients, and we're sort of taking that on in addition to what we do as transplant clinicians. So developing those educational resources, making things easy in the electronic medical record, and providing the ongoing education is super important. This just highlights the day 100 visit, which I talked to you guys about, but these we think are the really, really important things that should happen in that first year of transplant. And then we supplement it with this comprehensive consult visit at 1 year. I think I forgot to mention that we do have also a psychological evaluation and assessment as part of this visit. Again, we heard this afternoon how important the mental health journey is for our patients. So I guess you might ask me, does this work? Like, you just did a lot of talking, and we do think so. So this was a recent analysis that we did looking at 3 different time periods before we had our survivorship program, the first 3 years, and then the next 3 years after that. And we kind of looked at the different survivorship domains from a medical screening perspective. And you can see pretty much across the board, cardiovascular, ocular, cancer screening, and endocrine assessments all increased with the advent of the survivorship program. The one thing that didn't was pulmonary function testing in the COVID era when our PFT lab closed. So we couldn't overcome that, but we did really good in everything else. And I think just to drive this home, it wasn't so much that it was the survivorship specialists that were doing all this at the consult visit. We looked at incidence curves to like first time to screening test, and all these curves start to separate around day 100. So it really is that primary transplant team getting things started, getting the ball rolling, and that's was true pretty much across all the different metrics. Of course, the consult visit itself was helpful, particularly in getting people a cancer screening plan. Of the people that got to the consult, only like half had some type of cancer screening discussion, whereas once they got to the official consult, nearly everybody had a cancer screening plan in place. So we kind of view that consult visit as a reboot, as a check-in, and to make that longitudinal plan. We still don't have data necessarily on longitudinal screening, nor data on, overall survival that's associated with our transplant program. Ultimately, we need multi-center studies to be able to figure out what is the best model and also what is the association with hard patient outcomes here. But at least we can say, this is something that we think is helping our patients, and it truly does take a village to make it happen. So just to conclude here, formal and comprehensive survivorship programs are desperately needed, and they help patient adhere to complex medical screenings. Patients will always value the input of their transplant clinicians, so a culture of survivorship mattering is very important. And we don't know the best model of care, and I think that there's likely to be significant variation. What works in Boston may not work in Kansas, and it's upon us to try to figure out how to scale that. So of course, there's lots of stuff we can do better, and I think a really important part of our program is actually on that patient experience side. And we've used research in many ways to try to figure out how can we improve the quality of life and patient experience for our patients. Just to say it out loud here, will this apply to CAR T patients? We don't know. We just have started to do that and expand our survivorship program to include CAR T survivors. And are the efforts that we're doing at MGH, are they scalable? So we've tried to address that mostly through research, both in creating a database of patient-reported outcomes at that 1-year survivorship visit, and then using and leveraging that data to develop and test supportive care interventions. And we have a host of things that we've tried, particularly my mentor, Dr. El-Jawari, on developing clinician interventions, digital health interventions, and caregiver interventions. Two of those big areas that we've really focused on are interventions to help those who live with chronic GVHD and for those who have sexual health issues post-transplant. I'll talk a little bit about the Horizons effort, which is for chronic GVHD. And again, it was all focused on the psychosocial side of chronic GVHD is hard, and coping with it and developing a self-management, self-efficacy framework to sort of deal with this new chronic illness. So we did this group intervention where patients got to meet each other in a facilitated fashion with both a BMT clinician and a psychologist to go through each one of these key domains. And what we found was this coping with uncertainty was particularly important, and that we could take a lot of these lessons and actually build a digital app for that. And so we are now testing in a multi-site study both the group intervention as well as the digital application that translates that. And I want to show you some screenshots we have of this Horizons app. And again, we're hoping that one day this is going to be disseminated across transplant programs, but Horizons sort of takes people through the journey of chronic GVHD and gives people those lessons that they learn from each other. It gives education about what chronic GVHD is, across the different organ systems, includes pictures for patients and what they may expect in these different different manifestations of the illness. And then most importantly, it has videos about people's experience with it so that they can do that. Patients can then put their own experience back as tips that then get shared back to other users. So this is just, again, one way in which we're hoping to leverage technology in the survivorship space to be able to disseminate some of the things that we've learned in our program and hopefully make this a little bit of a scalable thing. We have other interventions that we are testing that are in development. One of my colleagues, Dr. Nelson, is doing a multimodal intervention to address fatigue. We have an occupational therapist working with us to develop a pilot intervention to help people return to work after day one, in that first year of transplant. And the list could go on and on. I think in medicine, we like for people to live longer and live better, and living better is such an important part of survivorship. So my conclusions for you today are that transplant patients and clinicians derive a lot of meaning and benefit from formal survivorship efforts, and I think it's a really critical part of what we do. We need better research and to figure out what's scalable, both to assess medical needs and also to better support patients. And the only way we're going to do that is with multi-center studies, given how variable transplant practices are across the country. And so thank you so much for having me. I hope I wasn't timing myself. So like a good way to cook brisket, you don't time it, you just let it go. And so hopefully I haven't stalled out too much, but thank you so much for having me.
Tony Sung, KUMC. Ryan, great work and great talk that you're doing. We struggle with many of these issues as well and thinking about how to implement them. One in particular, you mentioned Care BMT. We've been talking with Lexi Bassbinder and Salim Hayek and Mary Woods. The problem we've found in using it is that, if you look at allos, you look at older than 65, you're already at 5 points high risk there. So I'd love to learn more about how you're implementing and using Care BMT.
Yeah, it's a great question. I never, in terms of cardiovascular risk assessment, I never rely on one model alone. I sort of try to take things from different sources. We at Mass General, our transplant population is almost all older with pre-existing cardiovascular disease. So I would say for our patients, we're almost always routinely incorporating some type of aggressive cardiovascular management in our survivorship clinic. So it's always on the list of things that we have to address, almost independent of the score. Where I find it's the most helpful is in the middle-aged folks who don't appear to have other comorbidities, but maybe they're 62, they got an allo, and then it's just just by default, the normal ASCVD, they're low risk ASCVD, but they're maybe intermediate to high. And that's the time I find that score just a little bit of a reminder that let's just be more aggressive, because these other risk models developed in the general population, maybe they don't apply to you as much. The other score that I didn't mention that sometimes that I do use is I just go back to the HCT-CI score, because there's some data for that. I think ultimately we probably need a more robust transplant-specific cardiovascular risk calculator that incorporates not just the things I talked about, but also donor characteristics, whether that's donor chip, because we know that, or donor age, which is probably much more readily available. Though I think a lot of us are sending NGS post-transplant, so we kind of know what donor chip is, right? So I think we don't really know how to incorporate that information, but I think that's probably what's actually truthfully needed, and we can do a lot better than ASCVD or the model referenced here. Yeah.
And just to follow up, so do you have an algorithm for who you send to cardio-oncology, or is it kind of more just a gestalt?
Yeah, good question. I generally try to reserve the cardio-oncology referrals to people who have true ejection fraction decrements, like new heart failure, or an arrhythmia I can't easily manage myself. If it's just the primary prevention type stuff, we try to keep that in-house, and we have no, I would say for the most part, a lot of us have no hesitation, augmenting people's blood pressure regimens or figuring out how to manage their cholesterol, things of that nature. But once you get into actually having cardiovascular disease, whether that's an MI, heart failure, arrhythmia, those are the people we try to send.
Thank you.
All right. Thank you so much, everybody.